Hi, my name is Dr. Kirsten Butz, and I'm a psychiatrist who works for both Monument Health here in Rapid City, South Dakota, as well as for Avel eCare, which is formerly Avera eCare, a telemedicine group that serves a multitude of different states throughout our country, mostly regional, but some reach as far as Texas and Georgia, doing inpatient psychiatric consults as well as emergency room psychiatric consults. So today we're going to be talking practical psychiatric pearls for the internist. The CME learning objectives for today that I hope you'll be able to learn by the end of this presentation are, in the inpatient realm, to be able to identify some of the commonly encountered psychiatric presentations in the inpatient setting and their differential diagnoses, as well as the basics of the management of these diagnoses, and the protocols for appropriate psychiatric assessment of patients with suicidal behaviors. In the outpatient realm, I hope to give you some information about the evaluation of major outpatient psychiatric presentations and their DSM criteria, as well as the basics of treatment of these different diagnoses, and then what to do when the basics don't work. Consult liaison psychiatry is what we refer to as the inpatient care usually. Sometimes in the outpatient side, we see a more integrated care, collaborative care model, but psychosomatic medicine is another term that we use to describe this way that we interact together with our internal medicine colleagues, our family practice colleagues, to try and be part of a team to help patients with their mental health concerns. And we want to try and make these mental health concerns relatable and understandable for people in the medical side of things, and improve patient care via collaboration together. And then lastly, but likely most importantly, do a biopsychosocial cultural assessment that can help direct their care, and this has changed in the last 5 years or 7 years even since I graduated residency, whereas we used to just call it a biopsychosocial assessment, but we've added cultural to this, and I think that's really important and pertinent, especially here in Western South Dakota, where we see a lot of things that are culturally important with mental health context, especially in our Native American populations. And so those things are important to be included in our assessments. So to begin, suicide attempts and gestures. This is one of the most important things, I think, for me to give you as a pearl, because it is most likely the #1 thing we get consulted on and get called on from both an ER and an inpatient side, because it is so common and frequent. And so I spent a lot of time giving you information on what we do and things that you could hopefully take from our evaluations and use. And the beginning of this part of the presentation is just going to include some of the statistics from the CDC, and the most recent study in 2019, the Whiskers included that suicide was the 10th leading cause of death overall in the United States, claiming the lives of almost 50,000 people in that year. Suicide was the 2nd leading cause of death among individuals between the ages of 10 and 34, and I think that's really important to consider, that our young people are not only attempting but completing suicide at an alarming rate that puts that as the 2nd leading cause of death. And so there's concern there and alarm, as well as room for intervention. And then the 4th leading cause among individuals between ages 35 and 44. There is 2.5 times as many suicides in the United States as homicides in this year of 2019. And then the age-adjusted suicide rate in the United States has kind of been on a wave here, but 35% in 99, and that was at 10.5 per 100,000 to 14.5 per 100,000 in 2018, and then kind of went back down again in 2019 to 13.9 per 100,000. So it's just went up and down just a little bit over the last decade. When we look at attempts, we know that women attempt suicide a lot more than men. However, men complete suicide more than women, and the reason for that is because of the means. They usually use firearms or suffocation, which we usually think of that as hanging, and those are more lethal means, and so that's what leads to that higher completion rate. 95% of people who commit suicide usually have a diagnosable mental disorder. Now, whether that's been diagnosed or not is, not necessarily the case, but a lot of people have a mood disorder, 80%, so it's really high, and so that's something that we try and screen for after we see someone in the hospital, or when we see someone in the hospital. And the number one intervention that we try to take on if someone has an active mood disorder contributing to their suicide attempt. A smaller amount of people have a primary thought disorder such as schizophrenia. Even smaller have dementia or delirium, and then going back up a little bit, about a quarter have alcohol dependence, and I didn't include a statistic in here, but it's similar to a quarter also have substance use. This is just a slide that shows the completion methods, and obviously firearm is the most lethal in all of the completion. In 2018, this is about 50,000 deaths, and then hanging after that, and poisoning or overdose quite a bit below that. So risk factors, I spent a lot of time putting probably more information than you want to see on this slide, but that's because this is what we do as psychiatrists, in the meat and potatoes of our evaluation. This is what we are trained to do, and that's make a risk evaluation. And so we need to evaluate whether or not a patient is of a risk such that they should be admitted to an inpatient facility, whether or not they can go home without patient follow-up. And so that's what our job is to do. So these factors help us. We know that certain factors make people higher risk, but predicting exactly who's going to complete suicide is really hard and next to impossible. We just don't have a crystal ball looking into every person's eyes. But some of these factors really reliably help us predict, and so I use all of these factors on a pretty regular basis. And so I think that when you talk to me or one of my colleagues after you consult us and ask us about someone who has had a suicide attempt, and we talk about one of these risk factors, or you read one of our notes, and it's a maybe a conservative approach, it's likely because of one of these risk factors, and some of them are a lot more important than others. And so when we look at demographic risk factors, which are these ones here, male, sex, recent personal loss, single, widowed, or divorced, older age, we typically think is greater than 65, Caucasian, and socially isolated, all increase suicide risk. When we look at symptoms, severe depression, and so that goes back to linking to that 80% of people that have mood disorders. Also, if we think about severe depression, it's a really high risk of suicide completion. Anxiety to an extent, hopelessness, absolutely. It's always a question on our evaluation. Psychosis, yes, especially with coming into hallucinations that tell them to do something to harm themselves or others, obviously, as well. PTSD and insomnia both increase the risk. Substance abuse, for sure. Impulsivity, we always ask about that. Did you just do this on a whim? Tell me more. Why? What happened? Do you remember? That kind of thing. Agitation, and then medical illnesses also increase the risk, somewhat to a lower extent, but you unfortunately sometimes meet the patients that get diagnosed with the medical illnesses with a pretty grim prognosis, and those unfortunately sometimes lead to the higher risk for suicide. Suicidal thinking, and by that I mean, what are the specifics of how they thought about their suicide attempt? So did they have a specific plan? Was it, really rehearsed? Did they think about it for days on end before they did it? Do they actually have the means to carry out the plan? Or, if they haven't attempted and they're just thinking about it, do they have the means to carry out the plan? Do they own the gun? Is the gun safe, unlocked? Those kinds of things. What about the absence of protective factors? So, are they unwed? Do they have any children that they have to care for? Do they have pets? That kind of thing. Again, rehearsal of the plan, and then the high lethality of the method. So a low chance of rescue, where are they going to do this at? Are they going to take their phone? That kind of thing. And then there's an asterisk here about recent attempt. And so that's because one of the most predictive and highest factors for a risk of a completion of a suicide in the first year is after another attempt. And so we always have to assess of past history of suicide attempts. And then obviously, when we're seeing a patient who's just attempted, you can see why when we know that this is one of the highest risk factors that we have. We really are conservative, at least in my own personal practice, to let someone who's had a significant suicide attempt to go, even if they're saying, listen, I'm not suicidal today, if your suicide attempt was significant yesterday, it's not in the patient's best interest, and they're not necessarily safe to go home right away without being assessed, evaluated, and having the chance to get some benefit from the therapeutic milieu that an inpatient setting can give them. And so this is why we do this. And so that's a really important thing to remember, that a recent attempt is, one of the highest, if not the highest risk factor that we have. And so I always take that into consideration. And then, again, history, suicide attempts, family history of suicide, you always have to ask that. Has your family had any completed suicides? And active substance use, and then I always ask if there's any previous psychiatric hospitalizations for any reasons, because sometimes you uncover things. And then, recently, it's not part of this table here, but recently I've started to include in my risk factor analysis as something that's a little bit newer, but in my some of the newer thought processes in the psychiatric world and in my own personal thought process really makes sense. But one of the risk factors is, what about harm of other people? And that means, what about, the person who's going to complete suicide and leave themselves to be found by the child? That's a significant risk for someone else to be harmed. Not necessarily are they physically harmed by finding their dad or whoever, but they're obviously very scarred from an emotional standpoint, and that's a trauma that they may or may not ever recover from in their life. And so I take that into account absolutely on my risk analysis. And if they did that in their attempt and they survived, it's for sure a part of my analysis and part of the risk assessment when you'll see our notes. More on the risk assessment. This assessment is here and now. So we do have to, do some of it on what the patient is saying, but, the here and now can include the history. That's part of, my now is that I'm gathering the history. That's what I do, is gather history. I also gather collateral history, which can be like gold to me. And I wrote down here on this bullet here that the best tools to assess suicidal ideation are a thorough psych eval and collateral information. Sometimes I get a lot from a family member. And do I always, have an hour to talk to the dad or the brother or whoever? No, but sometimes I make it a point to do it because it's important. And so that's something that we can get a lot of information from. and then assessing the short versus long-term risk. To kind of go back up here, jump around a little bit, but we always have a short versus long-term risk. So what's the short-term risk is what we've already been talking about. The fact that you could have another suicide attempt right after a previous one is pretty high. A long-term risk, though, is someone that maybe has recovered, done well, their mood symptoms are under control, but they do have past history of a couple of attempts. Well, their long-term risk is likely always going to be elevated, and I'll usually talk about that in my risk assessment. And a presenting event, that includes some of the short-term stuff that we've really already talked about, but these are just some more questions that you could use to ask, what is the real degree of their hopelessness? What's in it for the future for them? What does the future include? What stopped them? How were they found, or who found them? Did they call, or did someone just randomly find them? And what was their attitude? How remorseful are they really? Assessing the need for an inpatient psychiatric hospitalization. So that's, why we do the risk assessment, to understand if we really need to put them in the hospital, because inpatient psychiatric hospitalizations are, not to be taken lightly. Often they do take away a patient's freedom, really. These are usually locked units, and patient can come and go as they please, and so that's a big deal. So we need to make sure that we use our risk assessment appropriately in that context. Even though I did say I'm rather conservative to protect a patient's life, we still have to take that part into context, and so sometimes that can be difficult. These inpatient psychiatric hospitals are oftentimes full, but that's the nature of the game. So are you guys all the time now, full too. And so how do we ration who gets what? And do we pick the sickest of the sick, or does who comes first? It's difficult in that context, and it's difficult in each region. And I think that has been something that I learn as I work in all these different states, whether it's Texas or Kansas, that may operate a little bit different. Virginia, where I trained, operated quite a bit different on the East Coast than, say, here in the Midwest. So the average length of stay in an inpatient psychiatric hospital is about 7 days, anywhere from a half to more than 100 days. The 100 days is more on the range of a inpatient psychiatric hospitalization at a state institution for someone who's seriously mentally ill, or maybe even a forensic unit on that end of things too. Most inpatient units, patients have to be medically stable. There are very few that are connected right in with a medical unit. In residency, I was blessed. We were just a floor on our hospital, and so we had a lot of medical support, so we could take a little bit sicker patients. We could do a little bit more things. I write here usually okay for the unit. Some of this presentation is something that I did in residency, and IV antibiotics, NG tubes, PEGs, all those things were they were okay, but not here, where we have a freestanding psychiatric unit and we don't have rounding teams of internal medicine residents coming every day. So I think that that's something you just have to take into context with whoever's the admitting psychiatrist. They should know their unit well enough to know what they can and cannot handle. And so normally tele's not a thing, and often anything with lines or danger to the patient is a no-no, which just kind of depends on staffing as well. Smoking privileges are usually a no-no as well, so I always ask the patient that, and I always have the consulting physician talk to the patient about that too. Listen, you can't smoke on this unit, it's not going to be fun, but we're going to give you a nicotine patch or some gum to try and cut the edge off. It's not going to be as good as smoking cigarettes, but we're going to do our best. And then, some of these, like I said, are going to be involuntary commitments, and that's also something that's usually not the most fun thing to do, but sometimes in the patient's best interest. And so we have to take on some roles there that feel a little more paternalistic, which in today's way of medicine is not as common, and so that can be difficult. A lot of times I have a lot of difficult conversations with patients about why I'm doing what I'm doing, and they don't love that, and don't love me for that, but I try and explain that it's the best for them, and you know, try to move on to the focusing the conversation on what we're going to do in a treatment sense there. Sometimes they have forced medications, not necessarily in South Dakota do you get that, but oftentimes in other places we can get judicial authorization. If someone's really sick, you can get medication over objection, and so then they can get started on a medication and get better. Here, you know, you have to be in the state mental institution to get that kind of care. Services provided: daily nursing care, social work, usually psych eval, and medication management, and then sometimes psychotherapy and occupational therapy and that kind of thing are all usually pretty standard in an inpatient psychiatric unit. A little bit more on admission. So it's generally indicated after a suicide attempt or a aborted suicide attempt if the patient's psychotic, the attempt was violent, non-lethal or near lethal or premeditated. They took precautions to avoid rescue or discovery. There's a persistent plan, or they still have intent. Distress is increasing and the patient regrets survival. And then these are kind of just, again, to talk about those risk factors that we've talked about over and over again. Poor judgment, refusal of help, patient has a change in mental status, that kind of thing. And then, you know, there's ongoing suicidal ideation with a specific plan and intent there. Moving on, delirium. So delirium is something that obviously you guys care for probably a lot more than I do, but it is something that we get consulted on a decent frequency. And so I put a slide on here just to kind of discuss about the percentage that we see of delirium. It's a pretty big range there, but 15 to 30%. There's really no, you know, a specific test to confirm it, bedside diagnosis. Usually we see a fairly, you know, abrupt onset, and it's oftentimes noticed first by the nurses or an OT or PT, or, you know, someone who spends a lot of time next to the patient or is noticing that something has changed and is calling us to ask for an eval or ask for some help because their executive function isn't what it was. And from an EEG standpoint, we often see a diffuse background delta theta, fast waves, and neuro, we see multifocal myoclonus with these frontal release signs, epilepsy signs, of grasp signs, executive dysfunction. We see that because of the frontal lobe signs. You know, orientation is plus or minus, usually minus, but not always. And then sometimes we do some tests, like, you know, say the muscle of the ear backwards, let's do a clock drawing test, or even the Luria test, which is that fist edge trap test that sometimes you'll see us do, and have the patient follow us. So delirium management, a lot of this was developed pre-COVID, and so this is information and recommendations based on when things were different, but, you know, non-pharmacologic management, screening at every shift, these calm orienting kinds of things, trying to have familiar objects from home, family there if possible, putting them near the nursing station, glasses and hearing aids, checking their fluids in their eyes and nose, and taking off all their non-needed medications. I understand, you know, those kinds of recommendations at this point in our state could be, you know, less than helpful, but that is what is kind of the known management of delirium recommendations, that we start with these non-pharmacologic things. And I guess what I've seen in the past in a more normal state of life is that having family members there is pretty calming, and then familiar objects helps patients a decent amount. And then if we need to use pharmacologic intervention, the atypical antipsychotics, if needed at low doses, are sometimes helpful, not necessarily, but they all have side effects, a black box warning for cardiac effects, so we do have to be aware of those. But something like a Zyprexa at 2.5 milligrams, if that's that dissolvable tablet, can be helpful, so you can avoid any injection if the patient is able to at least just chew that tablet or let it dissolve on their tongue. And then Risperdal makes an M-tab, you know, using half a milligram of one of those can be helpful sometimes. and that can be the beginning pharmacologic management, and the advanced pharmacologic management is calling us and asking for specific recommendations above that. Physical restraints only if needed, but we understand sometimes they are needed because sometimes we need them too in an inpatient psychiatric unit, and they're our last resort as well, but we get that. Keeping the patient safe is number one, so that also is an option here. Moving on to major depressive disorder now. This is the DSM diagnostic criteria here, and you need 5 or more of the following symptoms during a 2-week period to diagnose major depression, and that is depressed most of the day, nearly every day, tearful, sad, down, blue, diminished interest in pleasure, significant weight loss, or weight gain, we look at about a 5% change in a month, and insomnia, hypersomnia, psychomotor agitation or retardation, fatigue, loss of energy, feelings of worthlessness, inappropriate guilt, diminished ability to concentrate, and then recurrent thoughts of death or suicide. And so there's a pretty high lifetime prevalence of a unipolar depression. And so that's anywhere from 17 to 25%. We rule it out or in using the SIGI CAPS nomenclature. That's basically just these criterion put in an easy to remember nomenclature, and I'll give that to you on the next slide. And then we always have to rule out a bipolar affective disorder. That's that, not the unipolar depression, or that's the bipolar part of it. And I'll give those criteria to you too, but that's important for treatment. You have some modifiers to MDD, and that's, is this just once, or has it happened more than once? Is it mild, moderate, or severe, and with or without psychosis? And that's kind of, where we come in to help you further classify that, but those are just there for more information. These are the nomenclature that we talked about on the previous slide: sleep disturbance, interest reduced, guilt, energy loss, concentration problems, appetite problems, psychomotor agitation or retardation, and suicidality. So that's your SIG-E CAPS. So for treatment of MDD, we look at to first treat the comorbid conditions if needed to improve renal, cardiac, sodium status, and then look at their medication history, because we can have a lot of interactions, and so we need to know those kinds of things. So you'll probably hear us ask past questions when you call us for a consult about their medical history, and then we use SSRIs and SNRIs as kind of our first line. SSRIs are really our number one. I use Prozac really commonly at 20 milligrams starting dose, Zoloft 25 to 50, and the reason for the range there is a lot of people will just go right to 50. Zoloft's a good drug, but it's really activating, and a lot of people don't know this. And so if you do not warn someone that they're going to feel a little bit jumpy, sometimes more anxious, sometimes a little bit too up, sometimes trouble sleeping when you first start Zoloft, and with every subsequent increase in Zoloft, they might not have very good compliance. So this is something that I'm a pretty big stickler on with Zoloft, to make sure that we always have the range here of 25 to 50. I am really conservative with Zoloft. I like it, but I respect it. Lexapro I use it a lot. 10 is my starting dose. 20 is what I usually go up to, sometimes 30, but that's really under the guidance of a psychiatrist because it's above the FDA recommended. Cilax is not my best first choice. That's because of all the cardiac warnings on it, and we hit a ceiling pretty quickly on that with certain patients. Cymbalta, I use that a lot just because of the high prevalence of chronic pain in so many of our patients. All right, bipolar disorder. So like I said before, you have to rule out bipolar disorder to be able to diagnose MDD, and so that bipolar disorder really is an episode of mania or hypomania. So euphoric symptoms, 3 or more of these, or severe irritability plus 4 of these symptoms for over a week. So the mnemonic is dig fast, and their depressive episodes often just like just look like unipolar depression, sometimes just like worse than unipolar depression. People with bipolar disorder get really depressed, and they have depression that's really tough to treat. So that's a kind of a flag for me usually, both in the inpatient and outpatient world. If I've used a lot of different antidepressants and I'm struggling, I know that sometimes maybe I'll just repeat that really in-depth history about, is there any way I missed a bipolar disorder diagnosis or a manic episode at any point in their life, because sometimes that will be the case. So anyways, the mnemonic is dig fast, distractibility, needs you frustration, irresponsibility, erratic behavior, grandiosity, flight of ideas, increased activity, sleep, decrease in talkativeness. I ask a lot about the risk-taking, increased spending, traveling for no reason, too much sex, too much drugs, that kind of thing that really is outside of their character. And then the flight of ideas, you can get that from the interview. It's just you guys have all seen it, the jumping around in their train of thought, pacing, and you see these kind of dichotomous presentations of bipolar disorder. You see that happy, really talkative, difficult to interrupt, but still kind of jovial mania, and then you see the opposite side where they're really irritable, angry, mad, hyper-religious, psychotic mania. And so those are pretty classic, and oftentimes fairly easy to pick up once you see them. That's for a true mania. Hypomania is easier to miss. You just have to be very careful with the questions there. Agitation, the reason for agitation is the most important part of the puzzle to treatment. So if you can figure out what's causing the agitation, a lot of times you can treat it with some kind of fine line exceptions here. So cognitive disorder, that's not always treatable, or oftentimes not. So what can we do to help calm them down? That could reorient them or find something familiar for them. Drugs or withdrawal from, obviously something's already ingested. Sometimes we have to weather the storm or the withdrawal same way. There are some things we can do for withdrawal. A primary psychotic disorder, if we can figure out that diagnosis, then we can use what we have in our toolbox to treat the psychosis and sometimes help the agitation there. A difficult patient or person sometimes is the most difficult situation we run into in the context of agitation, because that's really difficult to treat. But what do we use? Oftentimes atypical antipsychotics. Zyprexa is our first go-to, and we use 10 Q1-hour PRN, but if you look at this, that looks like a lot, but you have a 20 milligram max per day, so really you have to watch that. You can give a couple of doses and then you're done, and that's what you have to watch that because of the cardiac effects. Geodon, same thing, but it's Q12, and 40 max is your 24-hour ceiling, so you have to be careful with the Geodon too. If you've gotten to those maxes and you're still having breakthrough, obviously call us, but sometimes I will give a little Haldol, Ativan, and Cogentin, or Benadryl if you want to call it a B52. Those things are helpful sometimes. Haldol's necessarily not the cleanest drug. We can have some significant cardiac side effects, but sometimes we have to use it. Risperidone and Seroquel can be used. They're just less fast acting and not necessarily our go-tos, but there are options if we run into using everything we've got before that. Astral force is something that can be super helpful. It's basically just having the team there. Sometimes it includes the security team, the law enforcement team, and showing the patient that that we're done. It's time to calm down, and that we need to focus on caring for you from a medical and mental health standpoint. And then restraints are really our last resort. They're our last resort too in the inpatient psychiatric world, but sometimes we have to do them because safety is number one. Violence. So this is just a little bit of information on the mental health and violence risk. So a lot of times mental health patients get tagged as violent right away. They're not necessarily always violent. So that's one thing that I think you need to kind of be aware of, that violence is not necessarily, schizophrenia does not necessarily equal violence. Delusions, that's a mixed bag. On the studies show their non-delusional suspiciousness can increase the risk for violence, so that's kind of paranoia. interpreting behind benign behavior as indicating a hostile event, and hallucinations. Not always. Many people are very pleasantly psychotic and hallucinating, hearing things, seeing things, but you do have an increased risk for violence if you have anxiety, sadness, anger, or the patient doesn't have good coping skills, and then there may be a relationship between these command auditory hallucinations. So essentially the voice they're hearing is telling them to do something, so we always have to ask a little bit of detail about the auditory hallucinations. And then negative psychotic symptoms, the social withdrawal can contribute in an opposite way to violence. So a little bit more on risk and violence. So some demographics that we know are associated with increased risk for violence: younger age, male gender, lower SES, poverty, lower intelligence, and less education. And then again, to talk more about past history. So past history of violence is the single best predictor of future violence, somewhat similar to our past history of suicide. So that begets more about our history taking importance. You know, the age at their first arrest is highly correlated with the persistence of the criminal record, and then again, you know, we have this increasing risk with the number of criminal events. So a little bit more on legal stuff. You know, we have this involuntary versus voluntary situation. You know, what if a person is needing an inpatient hospitalization and they're suicidal or homicidal or violent? Do we do this in an involuntary or voluntary way? We can involuntarily commit someone if they have a severe mental illness. Their severe mental illness causes them to be a danger to themselves, or they have a chronic disability, or others, and then they're likely to benefit from an inpatient treatment. The way that I tend to approach it with patients is, you know, first ask them for a voluntary commitment if they're able, and they have the ability to answer that question as I, you know, see fit from our interview. Then I let them, you know, give that first chance to say, yes, I'll go on a voluntary basis. That's always my first option. If that's not an option, then after that we have to pursue an involuntary commitment, but they always give the chance to go voluntarily in my eyes. And if we can't achieve that, or like I said, if they're not able to make that decision for themselves due to their psychosis or incapacitating situation, then we have to go a different route. So to move on and talk a little bit about some pearls for the outpatient world, we have a lot of the similar diagnoses that I've talked about, but I'll talk a little bit more about anxiety, because that's something I see a lot more of in the outpatient realm, and there's some of that in the inpatient realm, but oftentimes it lands people in my office as opposed to in the consult inpatient world. So we're going to do some discussion on that, because I think that there's a lot of anxiety, and anxiety tends to be one of our most common psychiatric diagnoses in general as a group of diagnoses, and so it is worth talking about here a little bit. Depression, same screening, SSRIs are first line, but there are some other options if the SSRIs or SNRIs don't work. Remeron should never be forgotten. Remeron's a drug that works well for both depression and anxiety. It works a little faster maybe than some of the SSRIs or NRIs, so if I have someone who's super anxious and they're just miserable, sometimes I'll think about Remeron, but they can't be someone who can't do with a little bit of extra weight, because Remeron can increase appetite and make someone sleepy. Obviously, at the very low doses, Remeron is more sedating than it is at the higher doses, and so this is a bit of a paradoxical effect, but you know, initially when you start Remeron, people can get really hungry, and so I always make sure that I pick this for the right patient. Well, Butrin is the opposite, so it has a little of that norepinephrine and dopamine in it that make it a little more activating, which also gives it its dual approval for ADHD. And so if I have someone that has a lot of concentration issues, their energy is really in the dumps, their focus is down, I will consider this. The one caveat to this is that sometimes Wellbutrin can cause a tiny bit of anxiety, not always, but sometimes because of its activating effects. So you have to really watch that. It's a fine line. And I've seen people get pretty agitated. I've seen Wellbutrin do a lot of good things for someone who has poor sex drive related to their mood issues, but I've seen it overdo it too, and so that's something that we have to be aware of. And then these two, vortioxetine and vilazodone, are both new drugs. I like them both. They can both be super helpful, and they have their own uses. They're a little bit harder to get though because they are so new and they're expensive. You know, to get an $800 a month medication, it's unreachable for most people unless you can prove that they've had trials of a couple of the other ones. And so these tend to be medications that I think of as, you know, used by psychiatrists more often than in, say, the primary care world. Augmentation strategies, Buspar and atypical antipsychotics can both be used. You know, Buspar can just be used to boost the serotonin effects, and atypicals as well. A lot of the atypicals have approvals for augmentation use with some of the antidepressants, and the one thing with them though is always to be careful because they cause weight gain, and so I tend to be really careful with the patients that don't have any wiggle room there and don't have any wiggle room on their blood sugars or their A1Cs, and so that's something that you got to be aware of. In the psychiatric world, we're using a little bit of metformin in this case in both our patients that are on long-term atypicals for primary thought disorder as well as for mood, and so that's something again that I think of more as a pretty specialized consult for a psychiatrist, but the information is out there in case you need to do that in your outpatient practice. TCAs and MAOIs as well as ketamine are just on here for your information. Obviously ketamine's coming up as used more frequently, not necessarily in a PCP's office, but it's being used, and then TCAs and MIOIs are still used to a lower extent though, mostly because of their side effects. I'm pretty stingy with my TCAs because of their lethality in overdose, so especially with a patient who's had a past suicide attempt, it's very rare that they're going to get more than 7 to 10 days at a time. It's a pain in the butt. They're going to have to refill it, you know, 4 or 5 times or 3 or 4 times a month, and an MAOI, you have to be careful with all the interactions and the food restrictions, and so those again I think of as a little bit more specialized and something that I would probably see as prescribed in a psychiatrist's office. Anxiety, so this is what I said we're going to talk a decent amount about here. Generalized anxiety and panic disorder are two of the things that I see super commonly in the outpatient world, and they are with such high prevalence in our population in our country, and obviously this has increased so much over the past year because of all that has been put on our plates, and so it's something that, you know, I talk about not only in my professional career, but oftentimes just in my social circles too. You know, people are struggling, and they'll ask me different questions about things that they could do to help themselves, and so this is not something that I think is unfrequent, and also it's a conversation that I'm always very happy to have and grateful that someone was able to open up and ask me for some information about, and that's why there's quite a bit of information here. So generalized anxiety disorder, diagnosed by excessive worry, and you know, it occurs on most days. 6 months is our time criterion. It's very difficult to control that worry, and then the worries associated with 3 or more of restlessness or feeling keyed up, being fatigued, difficulty concentrating, irritability, muscle tension, and sleep disturbance. And so That's kind of the diagnosis. The treatment, I guess from a pharmacologic standpoint, is SSRIs, SNRIs, and those are first line. Buspar can be used solo, and I think that that's helpful. And for very few patients, Buspar is helpful alone, and for a mild to moderate generalized anxiety disorder, it can be helpful, and I do see some patients do okay on Buspar alone. It can be a little fatiguing, so you have to be careful with that. For someone who's really high functioning, you have to warn them about that. You don't want to make someone who doesn't want to be tired during the day tired. And Atarax is used PRN. I don't know, Atarax really isn't my favorite drug. I don't like the anticholinergic side effects, but we have nothing good to be used PRN for anxiety. Do not use the benzos really ever. You don't even see them listed here, and they're just not a medication that is to be used on a long-term basis. Do they have a role? Yes. Their role is for very acute and directed use. So the benzos shouldn't be given for longer than 2 weeks, and that's in a routine use. And so I do give some people benzos, and it kind of depends on what they've gone through. A really bad life situation that causes a lot of anxiety, absolutely. Do I consider a benzo here for someone who I know is responsible? However, the dosing is low. I'm never giving more than 2 weeks. I'm not going to refill it, that kind of thing. I have a story here that will tie in with my last bullet point, but you'll see refractory as the next bullet point, but not approved as the atypicals. They can be helpful. They can kind of tie in the bookends sometimes when anxiety is so bad. So I think that that's something that I definitely consider. Again, it has to be the right person. The good thing about using an atypical antipsychotic for anxiety is you can use a really low dose, and so you have to worry a little bit less about the weight gain and metabolic disarray, because you can use 25 or even 12.5 of Seroquel twice a day to tie up the bookends. And you don't have to worry as much about the weight gain, but you're going to see as the next bullet point in bold and in capital is psychotherapy. So I tend to think of, generalized anxiety disorder, MDD, kind of all the things that I treat in the outpatient world as about 50-50 from a medication standpoint. About 50% of the time, we get it right, the medication works, and we get a good result, and that's that's the outpatient world. That's me having time to work with a patient, switch the medications around, having the chance to really get to know the patient, and that is the best of the best that I get 50% reduction in symptoms. Now, where is the other half? It's therapy. Absolutely. I'm a 100% believer in therapy. I love psychotherapy. I think it has a chance to change behavior, and that's what a lot of mental health is some of our behaviors need adjustments, and so I think that that's where the role comes in, and CBT can be super helpful in this respect. Now, is it accessible for everybody? No, and so that's why it's not always our first line. Sometimes we just have to do an SSRI because that's what people might be able to go to the drugstore and fill and take, and that's wishful thinking a lot of times anyways, and then trying to get someone to actually go to psychotherapy is a totally different ball. But if they can do it, it can be life-changing for people, and so I always recommend psychotherapy. It's kind of like exercise, can change your life in some respects. So I really work closely with a psychologist, counselors, that kind of thing, to try and get people involved in therapy if possible. To tell my story that I was going to talk about, I had a lady who had the most severe fear of travel, and she used to travel all the time, but she had a traumatizing event, and essentially would never leave her hometown again, and so she came to me for therapy, and I had her working with me twice a week for a year, and we were doing intensive CBT. She made a lot of strides. We started with little things like being able to drive out of town, and then a small plane trip to the next state, that kind of thing. And she eventually got back to her international travel. But in the meantime, she wanted something to be able to travel with. And so I gave her a 1/4 milligram of Xanax, 10 tabs. And I was a resident at the time, and so I had to get approval. My residency had a no benzodiazepine policy, and so I had to get approval from my chair to do this. And I went to him and I said, listen, I think she's really going to benefit from this, and I think that she's actually never going to take it, but she's going to put it in her pocket, and that's going to be her crutch. She's going to get on that plane and she's going to do fine. And that's exactly what happened. She never took it. And I told her, listen, these are your 10 1/4 milligram tabs of Xanax. I'm never refilling them, and I have to go, kind of above to get this refilled. And she never took them. So I think that speaks worlds about psychotherapy. So panic disorder, it's a lot of mirroring to GAD in its diagnoses, but essentially it just includes these really discrete episodes of intense anxiety that are precipitated by public transport, open spaces, enclosed spaces, crowds outside of the home, and so a lot of times it includes physical symptoms, and the individual really avoids these situations, and they provoke significant fear. And it's out of proportion to what the actual danger of the event or situation is, and then the individual really avoids them, or if they do them, they're endured with tons of stress. They last for 6 months or more, significant distress in their functioning or impairment in their social functioning, and that's not better explained by any of our other diagnoses. So SSRIs remain first line for this, but also is, again, the therapy and medication combo. So panic disorder really just has a lot of mirroring to GAD, and I just oftentimes see them as a combo diagnosis, and so I do the same thing for both of them. Insomnia is something I feel like you guys see a lot. Now we have a lot of sleep disorders, and I put them on this side of the slide, and you guys can see them, but we're not going to have time to go over all of these. So we'll go over ones that we can go over, but insomnia really is this dissatisfaction with the sleep quality, and so or initiating sleep, maintaining sleep, or early morning awakening, and it causes a significant distress or impairment in social, occupational, educational, academic, behavioral, or other impairment areas of functioning. So I think that this is super important because you guys see this all the time. 3 nights per week for 3 months. So what do we do? First line is CBTI. Again, you're going to hear this as a broken record, but therapy. There's a specific kind of CBT that focuses on insomnia. You can get this online. You can find a psychologist that will know how to do this, but online is oftentimes a reachable way that people can get some therapy to help with their insomnia. Trazodone is used all the time, but this is kind of usually new information for people. It's not really approved to be used for insomnia. It's just used so often as an off-label, but the sleep medicine people will say that they see more risk than they see benefit from trazodone, and I say the same thing. Like I've definitely used my fair share of trazodone, but I've also given my fair share of people go to hypotension and that kind of thing. So trazodone's not necessarily my go-to anymore. The orexin receptor agonists like suvorexant I do use. They are harder to get, though, so you usually have to work a little bit, and either yourself or have a decent amount of staff that can help you prove that the patient's tried other things to get those approved, but these are non-addicting. You can take them for a long time. The benzodiazepine receptor agonist, FAIR, they are approved in the sleep medicine world, and so, like I said, I don't use pure benzos, but will I use these? Oh, yeah. Do I keep people on them for a long time? No. This is not the patient that gets Ambien for 10 years. I pull them off, make them try to learn to sleep on their own. The idea is that the medication helps you relearn that, but then I'm taking it away. So it's not going to be your lifelong crutch. It's kind of like therapy where we talk about, listen, we're here today together talking about these things, but what are you going to do when I'm not here to talk about how we're going to navigate the situation? What you're going to do is you're going to think about what we talked about in this session, and hopefully you learn something that will help you in the real world. Benzos, yes, there are a few approved ones. I don't use them. Some people do, but I will, like I said, give them to the very specific situation of really ugly grief, really bad medical situations, that kind of thing. Absolutely. But just for primary insomnia, no. I don't like benzos because of the addictive potential. The melatonin agonists, like Melatonin, those are fine too. Here's my references. The APA practice guidelines for suicide. This is what I use a lot, and then my clinical practice guidelines are something that I go back to often. And then this is not an all-inclusive reference list, but I have a lot of other references that basically these are my pearls that I've taken with me from training and that I use on an everyday basis. This is just a conclusion slide that shows a picture kind of what I'm doing in most of the rest of my life when I'm not working. And this is my husband and then my 3 kids. And in the background, you can see my bike. And so those are things that basically I love the most in life and I do a lot of when I'm not working. And so that's the reason for this picture is I leave you with that, is that we do so much for so many other people, and doing something for yourself is often times my broken record in my office with my patients, is that, I hope that you do something for yourself today or this week, because you're worth it. And, what can you change in your schedule or your life to make you recognized and make your life a little bit better. And so that's what I want to end this presentation with, is just a little bit of that, because I love to do a lot of that kind of in my, outside of the nitty gritty of my big suicide evaluations. I love to just talk about with my friends and colleagues how they can help themselves live a better, more fulfilled life. And so that's the kind of the #1 thing that I see as a starting point, is giving back to yourself. So hopefully this presentation was